what are the tests we are doing here, and who should you send here. It's a very short presentation. So this is the video of the clinic there, which is room number 110. It's a very well done clinic, absolutely soundproof, and the calibration of the soundproof room is done very nicely. So whatever sound I'm presenting with the audiometer on this side of the screen is what is received at the child's level as well. Okay, so this was one. And then we have got, so
slide should have Kavita di.
Okay, so this is room number 110, which I showed you just now. Now, what are the tests we are doing here? We started the clinic on 22nd August 2022, and we are doing very 4 or 5 types of tests. First is newborn hearing screening, which is done at 0 to 6 months of age generally. Visual reinforcement audiometry, which is done in a child 6 months to 3 years of age. Then there is a play tone audiometry, which is done at 24 months of 2 to 5 years of age. And then pure tone audiometry, which is done 4 years onwards. Better diagnostic thresholds, will be starting soon, but let's see how the response of this clinic is. So the clinic timings are mainly OPDs are on Mondays, Wednesdays, and Fridays from 9 till 12. And for bookings, you can contact the OPD reception. Now, the basic thing, there are some rules for the audiology test battery. Whatever type of test of hearing we do to find out the hearing thresholds of a child, any test which gives us the information from various tests by giving the thresholds between 30 to 40 decibels and between frequency of 250 to 4000 hertz at a level of 30 to 40 decibels is the best test of hearing. Okay, any type of test says newborn hearing screening by otoacoustic emissions, visual reinforcement audiometry, play audiometry, pure tone audiometry, or BARA thresholds. Okay, so the other thing very important for the audiology test battery is a test should be able to know whether the child can detect the presence of sound, discriminate between the two speech sounds, identify and point out the difference between the two sounds. Like there is a cat's and a dog's bark. So the child should be able to make out the difference between the cats and the cat's meow and a dog's bark. So that is identifying the two and pointing out the difference. And finally, comprehend. So if we do not have the first three, we will never get the fourth. And that's why the speech will not come. Okay. So detection of sound is only about hearing. Hearing, which is done by most of the test of hearing. Discriminating between two sounds is listening. And the last two are comprehending and speaking. The second one is comprehending. The third one is comprehending. And the fourth is speaking. So until and unless the first three are present, we do not get the fourth one, which is speaking. So most of the child, this is 6 months to 5 years. 6 months can do a visual reinforcement audiometry very well. I'll show you, I've got a video from my clinic. Okay. Unfortunately, BARA test does not give any of this information. So every time you people writing, do a BARA test is not a very great idea. So it is best to write hearing evaluation or audiology assessment and leave the decision to the person who have referred the patient to. Okay. Because BARA test only gives you the sensitivity of the auditory pathways going to the brain and their proper working. That's all. It does not tell you anything about that. And we assume that if the pathways are working, then things are okay. That's our assumption. Okay. What happened most of the time, none of the audiology test gives all these 4 information. So we generally do a combination of the test battery. Okay. Now, newborn hearing screening, it is generally done in 0 to 6 months of age. It is done in all newborns. You should do newborn hearing screening in every newborn born on this earth. Okay, so leave about the NICU babies, preterm, low birth weight, IUGR, NICU graduate, they take a upper priority. So you should do the newborn hearing screening for every baby born on this earth. Now, generally the test we use is otoacoustic emission. It is a very good test. It is very simple, takes hardly 30 seconds to 40 seconds. but the only thing it tells you only about the cochlear pathway. It's easy to use, very economic, very less training is used, less affected by noise, and but has got a higher refer rate. Means the failure rates are little higher compared to the auditory brainstem responses, which is also a screening test, but not easy to use, not economic, more training is required, very much affected by the noise, and has a less refer rate. And it needs a very well training also, but it tells you about the pathway beyond the cochlea. So it is definitely a better test, but it's very cumbersome. The protocols we use generally is otoacoustic emission in a well baby population. Otoacoustic emissions, if the baby has passed, discharge the child with a checklist of sound. If the baby is referred, rescreen the baby either in the hospital or after 1 month of age. Now you can rescreen either with ABR or you can rescreen with OAE. If the baby has passed, discharge with the checklist of sound. If the baby is referred, then follow up in 3 weeks time. For NICU babies, the protocol is same, except that in spite of the past result, we have to follow them up for a review in the clinic after 3 to 4 months. Okay, to monitor any late onset progressive deafness. Now, when the baby has passed the newborn hearing screening, this is the type of report you will see from ICH clinic. Okay, normal cochlear function with age appropriate behavioral thresholds, which we generally perform there. And the parents have been explained the results in detail, checklist of sound, and follow up only if any concerns with sound localization or speech and developmental delay noted later. Okay, this is to be written to monitor any late onset progressive deafness. This is not there in the national protocol of newborn hearing screening. This is the checklist of sound we give to every patient coming to the clinic for newborn hearing screening. It is hanged up there in our room in the clinic. Now the visual reinforcement audiometry. Each sound signal is followed by a visual reward. I'll show you the video of this. It is generally done from 6 months to 4 years of age. The advantage is that no sedation is needed. Reliable thresholds can be obtained. Parents can witness the normal hearing of their child sitting there, and it is done in a free field. So the test is not ear specific, means you cannot test each ear specifically. So unilateral deafness can be missed out in this test. This is the one big disadvantage of this, which we have got the solution for that also. And the room needs a very good calibration, conditioning of the child. Normal development of the child is very important. Okay, so this is a video we have recorded from our room. Okay, don't worry, I'll show you the other one. I've got the videos there. Let me finish this. Okay, now newborn babies, there is no referral criteria. Refer all the babies born, as I told you. There is a referral criteria, but these days universal hearing is being promoted all over the country. So try and do as much as possible. Now, in a bigger child, who is the child who needs to be referred? Any child with speech and language developmental delay, with cognition problem or with other developmental delays, parental or a caregiver concern, failed neonatal screen or any underlying syndromal diagnosis, a child who does not respond in one go, a child who has got an unclear, unintelligent speech, missing out vowels and consonants and the nasal tone of the voice, who asks to repeat a lot and says ha all the time or turning the TV loud, speaks in a loud voice, any child with behavioral problems, temper tantrums, hyperactivity, poor academic performance, poor concentration and attention span. In last 1-2 months, we have seen 35 patients, out of which most of them were normal. Only one needed a BERA test, who probably was deaf, but he did not turn up. 10 were discharged, rest were advised therapies and other assessments. So most important, refer patients and write hearing evaluation, audiology assessment, speech and language developmental delay. Please do not write BERA or VRA test on the, because they come and ask you questions and it's very difficult to explain them. So this was the end of the presentation. I'll show you the videos now, just few of them. See, this is from our clinic. This is the visual reward which the child had after turning towards the sound. Okay. आया समझ में आया कुछ? अच्छा, next one is Nupur, you were asking for a, see, this is a VRA of a 7-month-old baby.